I remember the chairperson told me, "Oh, you think you are going to make any discovery? There will be many trials before anything is discovered." We presented the data of how many rings, etc., but we didn't know the results. And then we waited an eternity outside in a corridor. And we were thinking, what is going on? And then when they came out, they say, "You got it."
That was Dr. Maria Henao-Restrepo, formerly of the WHO, talking about the ring vaccination trial in 2014, 2015, when there was an Ebola outbreak in West Africa. She's painting a picture of sitting out in the corridor after just having presented to their data safety and monitoring board. As the investigators, they don't know what the data hold. They're presenting on the methods. And after sitting out in the corridor, they find out that, yeah, in fact, they did get it. The vaccine they were testing was incredibly effective. And it's now one of the approved and licensed vaccines for treating that strain of Ebola. Now, we find ourselves in the midst of another outbreak in the DRC, in Uganda, and there is no currently available vaccine for this species of Ebola. So once again, we're asking, what are the right trial methodologies for testing an Ebola vaccine during an outbreak? And in this conversation, we get a behind-the-scenes look at what it takes to design and implement a trial of this scale, of this magnitude, in such a short period of time in very difficult circumstances. There is something in here for everybody to learn about. If you're interested at all in trial design, this is a must listen for you. I'm Eric, and I hope you enjoy our conversation. Well, as of today or yesterday, we're in the midst of another Ebola outbreak. More than 600 confirmed cases, 100 plus confirmed deaths, and we're back to a situation of no approved vaccine. Probably nobody knows this better than you of the challenge of testing a vaccine during an emergency, during an outbreak like this. Tell us about the ring vaccination trial that happened a few years back and what you learned from it.
Okay, thank you for the invitation, Eric. So we are back in 2014, 2015. So as everybody heard, there was a large Ebola outbreak that compromised populations in three countries in West Africa, Guinea, Liberia, and Sierra Leone. And the outbreak was going on for a few months by the time that WHO declared it a public health emergency of international concern. And the international community then put all the resources together to really help these three countries to control the outbreak. As you noted, there were no vaccines, no treatments available at the time. So we were with thousands of people potentially being at risk of being infected, thousands of them also becoming actually infected and becoming cases, and not much to offer in the terms of medical contrameasures. It's also very important to note that all the previous Ebola site outbreaks were controlled with non-medical contrameasures, with good burial and safe and dignified burials, contact tracing, distancing, etc. So there was until then the belief that Ebola outbreaks occur in remote areas and could be controlled with non-medical contrameasures. So when this happens, there were a number of candidate vaccines in the pipeline. There was a vaccine from GSK, the Adeno 26 from Johnson & Johnson, the Chimpadeno from GSK, and also the rVSV, the vesicular stomatitis ZEBOV vaccine from a small biotech company. The first discussion was what can be done and which vaccines should be tested. So there was a big meeting, a senior meeting of all the leaders of these countries, plus the senior researchers and the developers. And it was agreed that all the three candidates should be tested until they fail. And this is very important to this story. So that was the first thing. The second that was happening is that there were clinical trials organized in Liberia with the government of Liberia and Liberian researchers supported by the National Institute of Health of the United States. There was also a clinical trial supported by the Centers for Disease Control in the United States in Sierra Leone, and a second trial also in Sierra Leone, this time the government collaborating with the London School of Hygiene and Tropical Medicine and Johnson & Johnson. So when we are having these senior meetings, the Guinean delegation says, but what about us? They were the center of the outbreak. This was where the outbreak was initiated, and it was a place where it seemed it was going to be harder to control it. And so there is when WHO, at the time, my boss was a person called Dr. Mary Paul Kinney, who is a French researcher. She decided, okay, let's discuss with the Guinean delegation and a handful of people what can be done in Guinea. But if we do a trial, if WHO does and supports a clinical trial, it cannot be an also run. It has to be a trial to really change the story of the outbreak. So it was really a challenge, no, to have a trial that is not an also run. And we are talking about now October of 2014. So
Right.
the question is which design? So the NIH has decided to go for an individual randomized clinical trial, and their initial sample size calculations is that they were going to vaccinate randomly with vaccine or placebo about 20,000 people.
And this is at the height of the outbreak, right? This is October
Yes.
2014, so we're getting close to the peak. Is that right?
Yes, exactly. And nobody knows when we are going to peak. So everybody
Right.
is, again, we are in front of a large outbreak. I can find 20,000 people, all of them at risk. In the Sierra Leone, they were more for the healthcare workers. They were saying we are going to focus our trials in healthcare workers because the healthcare workers are being infected, and it's true, particularly in the beginning of outbreaks when the infection control prevention measures are not fully in place and the PPEs are not fully available, healthcare workers get involved and become cases, particularly in the initial clusters. But later on, as the outbreak evolves and the control measures improve, there are less and less and fewer healthcare workers that get involved. But anyway, they decided they were going to go for healthcare workers. So the question is, what do we do? We have a vaccine that didn't have phase 1 data. And how do we get to the vaccine? So WHO organized a committee of independent experts. The three companies provided the information about their candidates, and they recommended to WHO and the Minister of Health of Guinea which of the candidates should be tested first in Guinea. First, because the idea was we could probably test 2 or 3 because the outbreak, remember, was going up. And then how do we go about it? So there was lots of debates. It was a huge camp, and we organized a coalition of 26 institutions. And there was a huge camp of people in the coalition who were insisting it has to be an individual randomized clinical trial. But many, including me and others, Raira Longini and several others, thought, no, this disease doesn't transmit in the general population. It transmits from person to person. It's a hard-to-get disease, and this is important for your students designing the trial. The first thing is you have to figure out who is at risk and how the disease transmits. So we thought it transmits through the social networks of the people. So it transmits to the family members, to the healthcare workers they visit when they are symptomatic, and also to the other members of the community they interact with, the people who transport them, the neighbors, the second-hand relatives, etc. Then we learn how is that the contact tracing works. And contact tracing focus only on the immediate contacts, yes? And by the time the contact tracing is implemented, maybe the next generation of cases is already occurring. So if you want to introduce a vaccination that is effective, we thought we need to go beyond the first line of contacts. And this is where we invented the idea of the contacts, how you go about the next generation. And then the third point is, how do you randomize? How do you decide what is the comparator? That was a huge debate. So we are here thinking that we have the unit of randomization will be the individual and his social networks, the contacts and the contacts of the contacts. But is it possible to have one cluster, one group of these people, one ring that receives the vaccine and another that receives the placebo? The policymakers in Guinea, the government says, no, we cannot accept that. that is going to be too much. If you think this vaccine may have a chance of work, you need to find another way. So after a lot of debate, we look at what was the serial interval. So how many days it takes for the next generation of cases to appear after one index case occur, and it was concluded it was about 21 days. So we say, okay, so if the comparator is going to be delay vaccination, that was the option that was acceptable, then we have to do it 21 days later. There was a lot of modeling, lots of discussions. We have a scientific advisory group. There was not really an easy answer because we didn't have all the information. It was evolving as the outbreak evolved. But we settled on 21 days. So we say the comparator is going to be delayed vaccination. It means one group of people that are considered at risk, contacts and contacts of contacts, the RIN, will be vaccinated immediately, and others will be randomly allocated to be vaccinated later on, 21 days, delay vaccination. Then the third point is, how do we do a trial in Guinea, a place where doesn't have a tradition of clinical research trials until then. Now it does, but at that moment. And how do we work on this? So we have a lot of discussion with other colleagues inside WHO, and we concluded that for the trial to be successful, it has to have three things. First, it has to be integrated into the outbreak response. It cannot be a parallel monster. It has to be integrated into the response and do not disturb the response. The second is that it should use the healthcare workers, the doctors and the nurses from the country. Of course, you have to train them in good clinical practice. Of course, you have to have SOPs. Of course, you have to comply with the international standards, but the local doctors, and not bring a lot of people from outside, because the communities were going to have issues. And the third thing was to have good social and community engagement, that it was key, that the teams respect all the traditions, the communication ways, etc. So we have to be integrated into the response using the local manpower and with a clear understanding of the social and community engagement. So with these three things in mind, then we work in a room in WHO, one of the meeting rooms, about 15 to 20 of us, on and off, for a full month, to write in parallel all the elements of the protocol. So at the same time that some of the people were, for example, deciding what is the target populations, others were writing the SOPs on how to identify eligible individuals. At the time that we were discussing how to randomize, others were writing the randomization approach. And so we did all that, and a third group of people were writing the dossiers for the regulatory authorities to approve the trial and the vaccine for evaluation. And that third point is good, because we didn't want to appear like WHO was taking advantage of the National Regulatory Authority in Guinea. WHO requested the government of Canada and the Regulatory Authority of Canada to work in parallel with the authorities in Guinea and discuss the dossier together to be sure that no cutting corners will occur during this process. So we have these three elements. And then we went and, of course, discussed with the president of Guinea at the time, Professor Alpha Conde, with the director of the Ebola response, Dr. Keita Sakova, who was instrumental for the success of the trial, because the trials in this context require the national authorities and the national policymakers to be fully involved and committed to that. And they provided all the support required. And then we got this coalition of the 26 institutions providing technical and scientific support, and also providing financial support. How do you get about getting the manpower? So we interview hundreds of doctors and nurses from Guinea and selected about 250 that were then trained with support from Professor Mike Levine from the University of Maryland and Professor Samba Sow from the Centers for Vaccine Development in Mali, and monitoring organization from Senegal. So we really use the horizontal south-to-south collaboration as much as possible. So we train them and on good clinical practice and all the SOPs. And this is people who just graduated from university where local doctors didn't have any sense of research, and to be sure that the system works according to international standards, because of course it's also a liability for WHO. We have to conduct the trial up to the highest standards. I think I can say I created a system that was everybody surveying everybody, more or less. So we have 100% monitors. So, for example, FDA requires 10 to 20% random evaluation of the documents in a clinical trial. We asked one of the donors to pay for 100% review of every document of the trial and 100% monitor in the field of the field activities. So we have a huge team of people monitoring and training at the same time, the colleagues and the collaborators from Guinea. And then we also created subgroups and groups with team leaders who have also responsibilities for the quality of each of the activities and were made accountable if we found problems during the auditing and monitoring. And that increased over time, and there is a publication by Professor Levine and Milagritos Tapia describing that exercise of ensuring high quality. Then the other thing is the logistics. Because the cases of Ebola were occurring in different villages, and you cannot just create a big, nice, wide center and put the tables and wait for the cases to occur all around you. They were jumping from village to village across Guinea. We have to have mobile teams, so we have to ensure that our researchers could go anywhere where there was an indexed case and go around in the town, the village of that index case, identify the relatives, the families, the friends, the places where the case he or she has visited when he or she was symptomatic, the taxi motos, etc., where he or she used to travel from A to B to C during the symptomatic period. So how do we do that? So, and before working on research, I work in the immunization program in the organization of National Immunization Days and Mass Campaigns. So I call them to my colleagues who are experts on logistics of mass vaccination campaigns, millions of people vaccinated in one weekend. And that working together, we created a mobile research center. And when we were talking, the leading person is Suleiman Kone, who also recently retired from WHO. He asked me, what is what you need, Ana Maria? I say, I need something like when you go to IKEA and you buy a box with a table inside, that it has the instructions with the diagram, and when you open it, everything is inside. So we need to have that like that. So we bought portable tables, portable chairs. We created boxes for each of the visits, boxes for recruitment, boxes for vaccination, boxes for follow-up, boxes for safety monitoring, etc. Transparent boxes actually from IKEA that we imported into Guinea. And then the teams will put all these boxes with all the safety stuff. And so we created a system to put all the rubbish and the used things in a way that could be incinerated right after. And it worked. And we have tents, like the ones they use in the markets, that were pliable. So they will come and open the tents and put it there. And we also work a lot on the appearance to get trust with the communities. So all our tents didn't have walls. So it means all the members of the village could see what was happening inside the tent. No, there was nothing hiding. It was all transparent. We insisted that the team members continue to dress like the locals in a very simple way, and they only have an ID that says, I am a researcher from the Ebola Sasufi trial, and that they were the social mobilizers, the community engagement people were local. So that meant that every time the virus moved to another locality, we have to identify a new group of people, train them, explain to them what the trial was about so they can communicate. Because in Guinea, there are many languages that are spoken in different areas. So just having a group of people who spoke one language who belong to a tribe, a different ethnic group, will not be sufficient. So, and we didn't have any posters, any leaflets, any pamphlets, because we learned by talking to the locals that people communicate through oral tradition. So we use oral tradition to communicate. So this is how it was established. The other thing that was quite a challenge was the analysis plan, the statistical analysis plan. there were a lot of discussions about which ones are the valid endpoints. Yes, so when you administer a vaccine, you don't expect the vaccine to be immediately effective. You know that it will take a few days for the immune system to mount a response that could be protective. But we didn't know how long will this now called RV vaccine, the rVSV-ZEBOV, will take to induce immunity. So there was a lot of people who will say at the time it will take 3 weeks. And so we say, okay, our 21 days separation between the immediate vaccination and the delayed vaccination is all right. Others will say it takes longer and you are underestimating this. This trial is going to be a disaster. You should postpone longer the delay group. But we say, no, that will not be acceptable for the authorities. There will not be trial. So we have these discussions. Some of the modelers in our group did modeling to decide how many days, etc. In the end, we calculated, and this is really discussing with people who knows a lot about Ebola and experts on clinical trials. We thought, okay, how many days it takes for the case to be identified from the onset of the symptoms to the identification. And so in average, at the beginning of an outbreak, it can take 1 or 2 weeks, but when the outbreak is already going on, it takes about a week. So we say, okay, let's say it's about a week. And what about the immune response in the animal study? So we look at that, and it looks like about a week was okay, but really, you know, immune responses in animals are not equal to immune responses in humans in absolute terms. So it was a discussion and an informed discussion with different experts. But then we settle on that. And we say the valid endpoints are going to be all of those who occur 10 or more days after the vaccination or the randomization.
I can't think of a more logistically challenging trial to design and to run under so much uncertainty and so much human suffering at the same time, so many moving pieces, and you're working in a very challenging environment, setting up these labs in boxes, these IKEA-style setups. And I even read somewhere that as the teams are out there finding index cases and identifying the rings, they're then calling back to your office to determine what the randomization is going to be.
Yes.
And then proceeding.
I was going to say that the other part of the analysis plan, statistical analysis plan, was the discussion of how we are going to randomize. And then there was some discussion about, well, we have to stratify and induce a different strata. So people start talking about urban and rural size of the rings, whether or not it's healthcare worker, no healthcare worker. And we thought, no, this is going to be too complex. We have to simplify that. So we simplified the randomization approach, and I think, if I recall, we only did some for urban and rural, but we really simplified that. The second thing is how this is going to happen. So of course, people talk about envelopes and teams living with the randomization already available, etc. But we were very conscious that the way, if the people knew, I'm talking about the contacts and the contacts of the contacts, if they knew during the recruitment and eligibility process that ring was going to be immediate or delay, that will bias the inclusion of people into the trial, and we didn't want that bias. So we wanted a system that ensures that you enumerate everybody before randomization, and that everybody signs off for the trial and signs the informed consent without knowing what the outcome of the randomization was. And so that was also a logistic thing, because it meant that you have in a village people coming and signing the informed consent and waiting to know whether or not they are in immediate or delayed ring. Because if they are in delay, it means nothing else will happen today. They will be visited 21 days later. So we have, with the support of the University of Bern, created a unit also manned by Guinean trained technicians to run the randomization. And they have to call, we have mobile phones, that was quite a novelty 10 years ago, to have all these funds everywhere, they have to call, and then the randomization will take place, and then they will be informed. And once they hear the outcome of randomization is immediate vaccination, then another part of the team will drive there, and the vaccination will start. And to achieve that, then we have to divide. So you have a team, let's say team number one, and team number one typically will have 4 units. The first unit, that's the redefinition unit. Yes. The second unit is the vaccination unit. The third unit is the adverse events follow-up unit for the day of vaccination, and a fourth unit that is the follow-up for other days beyond the vaccination day, because you have an acute 30-minute vaccination unit, but you have a vaccination unit. So each team was composed of subunits. And that helped us to recruit people who didn't know what was going to be the outcome of vaccination. And I must say, the compliance was quite high. We got better and better over time, but it was quite high, better than we suspected it was going to be. And then when we have the statistical analysis plan, there was also a lot of discussions about intention to treat and per protocol. Debates of which is the best one, if it's us. And so in the end, we did the two, as you read in our publications. And we did some, I don't know, mistakes, but I think we omitted some. So when we did first the preliminary and interim analysis, there was a lot of discussion about alpha spending too, and how much alpha we spent by doing that interim analysis. And I understand that if you are a purist statistician, you don't want to spend any alpha because it reduces the power of your study with an interim analysis. But if you are in the middle of an outbreak with a vaccine that it appears to be working, then you cannot tell the national authorities that you are waiting for the perfect statistics before you do the analysis.
Am I remembering correctly at the interim, you have 0 new cases among the vaccinated, the immediate vaccination arm, versus 16 maybe among the delayed vaccination. So you had this early evidence, and then the DSMB weighs in on this alpha spending issue, right?
Yeah, so we WHO and our team, we didn't have any data. The data was managed by the University of Bern, as I mentioned, and the national colleagues. So I personally, I was leading it, but I didn't have access to the data. But it was becoming very evident that the vaccine was working, because let's say there is a village where there were 1, 2, 3, 4 cases, because in the beginning we could not go after every case. As the trial was building up and we were training the teams, there were cases that we could not include in the trial as index cases. But over a period of a month or so, we were able to go after every case that was confirmed. And when during that period we could not go through every case, then of course everybody was seeing that where the research team will go, that village transmission finished. Sooner or later, the other villages kept going. So people start saying, "Oh, you have to come to this village. We don't manage to." I said, "No, it doesn't work like that, my dear. There is a randomization and blah blah." So they were like, "Oh, okay, we wait then." And so when we have the DSMB was very skeptic. I remember the chairperson told me. He was a very experienced statistician from the HIV/AIDS vaccines. He told me, "Oh, you think you are going to make any discovery? No discovery. There will be many trials before anything is discovered." I said, "No, I am not for any discovery. I would like for you to consider the data if possible." And so they considered their data. And he had told me, "Oh, it's going to be a Zoom call." No, a teleconference. This is the period of. It's going to be a teleconference. I said, "Okay, fine. No need for the DSMB to get together." I said, "Fine with me." And like 24 hours later or 36 hours later, they call me and say that it's going to be an in-person meeting, and that I have to produce myself with the team in Oxford, because the statistician of the DSMB was Professor Sir Richard Pito. So I say, okay, so we went there and they asked us to enter. We presented the data of how many rings, etc., but we didn't know the results. And then when they came out, and we waited like for 4 hours, an eternity outside in a corridor. And we were thinking, what is going on? What is going on? And then when they came out, they say, you got it. And I say, what did we get? And then they say, oh, I think it was 0 versus 13 the first time. And I was like, what? He said, yes. Wow. And then I couldn't believe it. So I called, and then they said, you cannot tell anybody. You cannot tell anybody. I said, no, I have to tell my boss at least. So I called her, Mary Paul Kinney, and she was like, we have to tell people. I said, no, you cannot tell anybody. And so we were like, yes, so we were like, wow, what are we going to do? So the DSMB took like 24 hours to write a formal report, and we were waiting to see what they were going to recommend, because they didn't give all the details, and so we could not say or do anything. And then they wrote the report, and they recommended at the time that because of the outbreak and the severity of the disease, and because the data was quite striking, that they suggested that the rings that were already randomized should be continued for follow-up, but the randomization should stop and only immediate vaccination took place. So, yeah, so it was quite challenging. And then we have to publish. So we actually wrote our first publication in a week. The manuscript was prepared in a week, because we have the commitment and also the obligation to communicate. We cannot say that that is changing without having a peer-reviewed publication. And so we wrote it very quickly. And, if we have had more times, I think we would have been better. But anyway, we wrote it very quickly. And yes, we did lots of analysis, and I learned that the best is to put everything in the supplemental material. And because we were very purist, and we put only the things that were in the statistical analysis plan, and yeah, I learned, and also because it was a big group of collaborators, then you have to get consensus from everybody for every table, for every plan measure, for every graph, and it was quite hard to get everybody on board. And I think there was a lot of debate afterwards. Some of them constructive. I learned a lot from some of the debate. Some of them very destructive and negative, and sounded more like jealousy to me. Like, why are not you happy that the people in Africa don't have to die from Ebola anymore? Why are you so bitter about it? But anyway, it was quite interesting, and I think for the students it's very important to have that statistical analysis plan discussed at length before, and we didn't have that luxury. But I learned afterwards that you really need to sit down and consider that statistical analysis plan in detail, because otherwise it brings you headaches. If you just go for the standard and you don't really go through all the motions. And
your statisticians might have been surprised by this, but I'm guessing that Dr. Henderson and anybody involved in smallpox was not all that surprised.
No, I forgot to
when they
mention
learned
that. I forgot to mention, I'm so sorry, I forgot DA. But what happens is, when we started discussing in the beginning, so people wanted to have a cluster randomized trial, and then some of them even will go around and say they invented the ring vaccination trial, but nobody invented the ring vaccination trial. It was the outcome of hours of debate of different individuals, and whoever says they invented it, I can tell you they are not telling you the truth. It was a contribution of many people. So when we were discussing that, I knew D.A. Henderson because I work on polio eradication in the Americas, and he was the chair of the technical advisory group of PAHO, and he also was the boss during the smallpox, so the person who was leading polio eradication in the Americas, Ciro de Cuadros. Anyway, I knew him for years. So I called him and I told him that we were trying to do something for Ebola, that Ebola has the same basic reproductive number, similar ways of transmission, blah, blah, blah. And what do you think? And so he explained to me surveillance and containment. And we have several phone calls about the protocol. And he gave me a lot of the practical issues that work very well. And my boss, Mary Paul Kinney, she also said that she is convinced that the trial worked because I have a lot of experience with the immunization programs and mass campaigns, and then my experience on research and putting the two together was what make it possible. So yeah, for DA it was obvious. When I called him, he saw it, and he asked me actually to call him when we do the first ring and tell him what happened. So we were in a village in Guinea, and Koya, near Koya, and I was thinking about like 4 p.m. or something, the ring was over, and I called him with the mobile phone, and luckily there was signal because the signal is not very good all over Guinea. And I called him, he was still alive. And I thought he was going to ask me methodological questions, but guess what he asked me? He asked me to tell him how the village looks like. And so I described the village to him, and he was very happy, and he told me that I have to go back to the hotel and take a beer with the team. That this is what he means the most out of the eradication program, the beer with the team at the end of a good day. No, so he was very good. And when we got the results, I told him that we were going to publish the results. And I think I sent the manuscript, the draft of the manuscript, and he wrote to me a lovely, lovely email that was like a premonition, like a prophecy. Because in that message, he told me that there will be some people who will be very happy, not about me, but about this vaccine helping people in Africa. But there will be a lot of other people who will be not constructive and etc. And that I should focus on what motivated me and the others to go to Guinea to work with the Guinean researchers and forget about the rest. And so I did. So when that happened, I sort of was psychologically prepared by DA.
Well, from Dr. Henderson to you to the next trainees, that's good advice to be passing down to celebrate those wins. Now, congratulations is in order. You're retired after nearly 30 years with the WHO. So I have to know, when you're sitting in the hallway waiting for the DSMB to let you back in after you've presented the methods, not knowing the results, is that the high water mark for your career? Is that the best moment in science for you, or can you top that?
No, I want to say that that was quite exciting, but I worked on polio eradication before, so I had Ciro de Cuadros, the person I talk, and DA, and others. We were about 15 who work on polio eradication in the Americas. In 1994, we have a party in the house of Ciro de Cuadros to celebrate there were no cases of polio in the last 3 years in Latin America. That was really cool, and I was younger, and I thought this is very enthusiastic and very nice. And then a couple of years later, I went to East Africa, Uganda, Kenya, Zambia, and Tanzania, and I helped the national EPI managers to organize the first national immunization days in Africa. That was super cool because then it was my first time in Africa, and I realized how much we do have in common, including in the challenges. And for them, I think it was refreshing to see somebody from the South that worked with them and understood their issues. And when the first national immunization days took place and they got more than 95% coverage in both rounds of the first NIDs in Africa, I was over the moon. And I want to say this is not things I do on my own. The thing that I really, really love of WHO and public health is working in a team and contributing to the team. And then After that, I went to Geneva. No, I went to India, and I worked on polio eradication in India.
If your experience on this blockbuster trial for an Ebola vaccine is only top 5 in your career, I think that's a good indication of a very successful and interesting career. So I have to ask, your medical doctor, how did you get into this line of work?
I wanted to be a surgeon. This is why I studied medicine. And my mother also wanted to have a daughter that was a surgeon. And there were not many female surgeons in Colombia when I studied medicine. So I was determined to do that. And the last year of medical school, there was somebody from the Red Cross and came to the university where I was, Universidad del Rosario, and said they were looking for volunteers to go in a health brigade in the Pacific coast of Colombia, to go to places where there is no doctors. And a friend of mine and I thought, oh, it's exciting, going to the jungle, sounds like an interesting trip, but no more than that. And so we signed up, and we thought we were going to be together in the jungle. And little did we know that as soon as we got to the next town, they split us into teams, so I never saw her. And they put me with a bunch of people I didn't know. And we spent 2 weeks traveling in the Pacific coast of Colombia. There are no roads. You have to travel mostly in canoes from village to village. And there are places that even today do not have regular access to health services. And in my team, there was a person who is still my friend, who was much older than me at the time, who was the director of the medical services for the Pacific coast of Colombia. And he was very upset that the people who have come were these junior doctors, some of them like me, not even graduated. And I was so unlucky or lucky that I was in his team. And he spent the whole 2 weeks mistreating us in the sense that, oh, you don't know what you are doing, you are city boys and girls, upper middle class, blah, blah, blah. And so we went to every village, and he gave rules of respect for the villagers. He told us not to promise anything. And then he made us work the entire day from like 5 o'clock in the morning until 8 with candles, because he says these people have come in the canoes for hours and hours just to be seen by a doctor. So we cannot stop. And then after we did that, he forced us, encouraged us strongly to sit in the village with the community to listen to their problems, and told us that we cannot promise anything. We just have to listen. And after 2 weeks of that, I came back and announced to my mother that I was going to do tropical medicine and not be a surgeon. So that is what happened. And I am still friends with him.
Well, thank you very much for talking about this really groundbreaking trial and giving insight into a lot of the hard decisions that happen behind the scenes, and especially in a compressed timeline and very challenging conditions. This is a very interesting one.
Yeah, I think the best part of all of it is not that trial, is that after that trial, it became the norm that when there is an outbreak and there are no medical countermeasures, research must be integrated into the outbreak response. And talking about Bundibuyo, this is what is happening now. And it happens in every outbreak in the past decade after we did Sasufi in Guinea. I think that's the best, that it transformed the entire system and also transformed the prejudice that people in these countries could not do trials of high quality, that it was not possible to conduct trials that will lead to licensures of vaccines. I think that's the best, and that will be what I take home.
That's a great lesson.